Professor Xue here to have our collaborative joint session regarding the academic journey oncology 2025 ASCO Frontier Express and Urological Oncology Treatment Progress Exchange Series meeting. And I'm the host today, and I'm an associate professor in Renji Hospital Department of Urology under Professor Wei Xue's mentorship. And so the first session is, please allow me to introduce the chairpersons tonight. Okay, so here first we have our chairperson, Professor Wei Xue here, and Professor Xue is currently the vice president of Renji Hospital, affiliated to Shanghai Jiao University School of Medicine, and president of Nantong First People's Hospital, and also the chief physician, the level 2 professor and the PhD supervisor in Shanghai Jiao University. And Professor Xue has a lot of titles in academic society, including the standing committee member of Chinese Urological Association, the chairman of Urological Association of Shanghai Medical Association, and also the director of Shanghai Urology Clinical Quality Control Center, and etc. So first, please welcome our chairperson, Professor Wei Xue, to give us a welcome words.
Okay, respected. Respected Professor Shigeo and respected colleagues, good evening. I'm so glad to have this opportunity to use this Monday evening to gather here online together with Professor Shigeo to do a urology communication and exchanges. We are very close neighbors, and we hope that in the future we would have more opportunities to have more communication and exchanges with the urology colleagues from Japan. And thank you.
And Professor.
Could you
Sorry, Professor. I think they have some internet issues to be solved.
yeah, could you hear me? Okay.
Yes, I can hear you.
Okay,
yes.
So sorry, please allow me to introduce you again.
Good evening, everybody, and Professor Dong, Professor Chu, Professor Gu, Professor Pan, and Professor Guo. Thank you so much for inviting me today for this wonderful meeting, China-Japan Exchange Summit. And my name is Shigeo Horie. I'm the Provincial Chairman of Juntendo University Graduate School of Medicine. I will introduce my institute later in my talk, but Juntendo is the largest university hospital groups in Japan, and also actually the oldest medical institute in Japan. So I'm very happy to join this, seminar, and also very much looking forward to discussing many issues with Chinese colleagues. Thank you so much.
Thank you. Okay, so next we'll move on to our first presentation session. And sorry, where's my screen? Okay, so according to the agenda, first we will welcome Professor Wei Xue to give the talk, Renji Urology, Discipline Development and Operational Management. Please welcome.
共享怎么弄的？真的，慢慢共享了。好不好？我看一下。你就或者共享一下，谁有听？好像是，对。 不是他共享不是就他来弄，
他给你翻译啊？
我来自己来翻译。
这个应该电脑里，电脑里有吗？
这两里有的这台，那个有口这方面我来，之前已经都下好了。然后这里上线而有，
在这里。
没有共享，看一下。然后确定一下。
看不到，看不到，现在看到了吗？
有了。
OK，
有延时，他们现在能看得到吗？你们
可以看得到，
可以
我们都能看到。
OK，
好，这。
倔强，
我忘记了，这个
倔强。
尊敬的这倔强教授，非常荣幸。
Respected Professor Shigeo, I'm so honored to have this opportunity to meet you online and also to have the opportunity to introduce some of our own experiences in Renji Urology. Well, I would have the following aspects to do my introduction and sharing. Well, we know that for Renji Urology, it is a pioneer in the field of urology in China. We have accumulated very abundant experiences and we just have a very long history. Well, here, firstly, I would like to introduce that for Renji Hospital, we established this hospital from 1844. This is already over 200 history. Well, for our urology department at the very earliest time, is established in 1937. And at that time, the Professor Chen Bangdian, when he came back from US, just established the Department of Urology. That is the year 1945, and Professor Chen Bangdian became our president. And in the next years, Professor Wang Yixin just led the development of our discipline. And that is the original body for the discipline of urology in Renji Hospital. And well, in China, we know that we have 5 pioneers in the discipline of urology, and 2 of them come from our hospital, the Renji Hospital. And now in China, we also have established this state key discipline. And also in the city of Shanghai, we are the Shanghai Key Research Center of Urological Tumors, as well as the president unit of the Yangtze River Delta Urology. So in the city of Shanghai, we are the largest as well as in the whole country. Well, now in the Renji Hospital, we have 4 campuses. Among them, well, all of the different campuses, they have the Department of Urology. Well, mainly we reside in 3 campuses in the east, west, and south. And for the northern campus, it is specifically for subclinical, and we have 10 sub-disciplines through since 2005. And now we have 238 beds available. And always we are advocating. We have the special doctors in this department. to increase our working efficiency. And for Renji Urology, that what we know is that well, the whole country would recognize our medical service quality. This would be our greatest character. And the clinical volume is very huge. Well, in 2024, it is almost 500,000, and almost 30% of the patients they are treated in the Renji Urology for the tumor patients. And in recent years, with the promotion and the popularization of the robotic-assisted surgery, we are the exclusive leader nationwide. Here it shows the annual number of robotic surgeries yearly. Well, now in our hospital, we have 4 Da Vinci machines, and every year in our department, for the surgery volume, it would almost 3,600. And I estimate that for this year, we would also surpass the last year's number. And during the whole process of work for the renal tumors and bladder, for the radical cystectomy and the partial nephrectomy, as well as the urotractor stones and different technologies, we have them all. And also we emphasize that the academic exchanges, we're also doing some academic collaborations as well as exchanges with foreign colleagues. Well, together with the Medical Center of Toronto University in Canada, we have done some of the researches in the prognosis of prostate cancer, and we found that in the treatment of the prostate cancers, from the radical surgeries, the patients need to receive endocrine therapy, the different time points. And for the non-metastatic survival, the HT-free survival and metastatic-free survival, they do not have great difference from ASI to WES. And from the cross-sectional study, we have PSA and Gleason scoring. Generally, in the Chinese population, it would be higher than the European population. And currently, in our hospital, we have established these subdiscipline of the ER for urology. And for this subdiscipline, well, in the city of Shanghai, this is very seldomly seen in the same level of hospitals. We can just radiate not only the city of Shanghai, but the surrounding places like Jiangsu province, Zhejiang province, and Anhui province, just all the provinces surrounding Shanghai. So from this point, well, for the patients with very severe symptoms of the whole urology systems, you would have a very good diagnostic as well as therapeutic characters, and also under the support of the government, we just have set this general direction of the strategic collaboration of the whole area, of the whole region. So we have established the Smart Medical Development Alliance of the Yangtze River Delta City Economic Coordination Conference. And at the same time, we just pay a lot of attention to the international communications. I have visited in MD Anderson, and Dr. Zhong Liang has studied in the Cleveland clinic. And also we have professors visiting Japan and other countries. Now we have built the ties with centers in France and Germany and in Korea. And also we are very looking forward to that together with Professor Shigeo, we can do better cooperations in the future with more colleagues from Japan. And from the facilities and equipment, we have 4 robotic surgery systems. It is very comprehensive. for all of the different urological surgical equipment, and also in prostate cancer.
We can see that for the treatment, and especially for the HIFU, and also for like many of these very cutting-edge technologies has all equipped in our hospital, and then we have carried out very smooth operations with this like hardware facilities as well, so that we have also get internationally and also domestically credited for the education and the training platforms. And in our hospital per se, that for the scale of for performance in the hospital is actually ranked quite top in China. And then we have more than 496,000 number of the outpatient and emergency visits. And also we can see that in China, many of the patients are accumulated or more centralized in those tertiary hospitals. And then we are also I'm also pay attention to this entire like healthcare system, so that we can also reflect our focus and our attention to the patient care on the numbers that we have committed year on year. And for the day surgery, we can see that we have almost 75%, which is like 3/4 of the patient is accounting for the daytime hospitalization and of the total hospitalization cases. So especially in the recent years that we are more focusing on the day surgeries rather than for these like selected surgeries. So we can significantly enhance it for the clinical service capabilities of the disciplines and the different specialties. And for the evaluation and assessment indications, we can see from like 2016 until now that we are still remaining for the leading positions in China. And in our specialty per se, I think we could also have some like discussions and with our Japanese expert as well, because that most of our physicians has been studied in the United States, so that we have been adapting for the just like American models. And then we have a like a big outpatient and a like a relatively smaller inpatient. So that this is what we are doing right now. And we are also like calculating for the cost and also try to balancing for the cost and revenues. And then especially that how could we establish a more sustained like platforms and also a more sustained systems. And also we can see that now for the doctors, they are very, very busy. And we have 3 campuses in total. And because we are treating like specialty diseases, so our specialty physicians and the surgeons, they have to perform like a cross-campus surgeries or the other works. So that among the 3 different campuses, we need to have a better information system to like keep everybody just on the same page. And when I was actually communicate with colleagues from France, they also ask us like, I mean, just like every day that you have to work over just like 12 hours and work like 7 days a week. I mean, like this is like a huge pressure. And because indeed, I mean, like in China, we have a very big population base. The patient volume is very significant. So we really wanted to provide as much as the best care that we can to the most patients. And we have a team, and then we are like dedicated to cultivating for the trustworthy medical system team, and then including for those managers, including for the information officers, research officers, etc., and others to have a more like collaborative for the models of the work. And then now that we are also not only for the pioneering and also we're having for this innovations of the day surgery, but also now that we have transit or transformed from day surgery to the same day discharge surgery. So everyone knows that in China, we still have a relatively limited resource of these medical resources, and we have a very big population base, and then many of the cost, and also we have like significant saving in the cost of the medical care for our patient. So from the same-day surgery, we have calculated like roughly that we can do more than 20,000 more surgeries in a year. And at the same time, we can reduce the cost of each patient by about 20%, which is a very good like result. And we can see that now, and we have more of the patient can be discharged on the same day of the surgery. And I think for the same day surgeries as settled as for the inpatient procedures, and for our like urology department has begun attempting the same day surgeries as early as 2016 to 2017. Now that we have like 40%, or so we have like 60% to 70% of the patient in certain specific and like mature surgeries were able to underwent for the same day surgeries. And we can see that in here, this is our just research like teams. They are like the top expert, both on the like basic research per se, as well as for the clinical trials. And also we have introduced a younger PI from the US, and then who has joined us in 2017 from University of like Illinois. And he has now become a full-time PI and dedicated the time to the scientific research. And like every week, actually, he will have around like 2 to 3 days of the time, like dedicating to the research as well as to the teachings. And today, that through for the communication with our Japanese expert, we also wanted to see that if we can facilitate for some like co-trainings of our young talent, because this is our hospital's like tradition, and we do have like many of our young talents. They have already been studied or trained in just Europe and also in the United States. And we do have just like for those like 3-year plans, and some of them has already like returned to our department, and then they become for the backbones of our specialty. And then I think this and on this slide you can see this is some of characteristics of our department. We can see that, especially in Shanghai, that we have this sort of like genetic like kidney diseases, which is having a very high prevalence. And then we have largest databases in China for the kidney disease patient. And also for the kidney cancer, actually, it has been just like 12 years in a row that in Shanghai that we ranked the first on treating for the kidney cancer. And also, I mean, like in our hospital, we ranked the first in Shanghai, and also we ranked the first in the kidney cancer treatment in China as well. So this is one of our focus in our department as well as in our hospital. So for the basic research per se, that we are also very enhanced on the significance of the basic research on this prostate cancer. And we're also trying to like leveraging for the knowledge and also for those like innovative like breakthroughs generated from those basic science to facilitate for our like clinical trials. Just for example, in those like to this like liquid biopsies, etc. And then we have also established the panels in China, and then to do a like better treatment, and then we can have better like diagnosis, and also we can find a better just like gene mutations of the patient. I think when carried out for the liquid biopsy, and then it can provide the precision treatment, and we can see that for the result of this like liquid biopsy and also with the like tissue testing is like very much consistent. So we do have like better ways to do interventions to treat the patient, and we also have getting some support for our like big projects to carry out further studies. So we're also very like honored that in our hospital we have a very strong like research capability, and in China that our research team is very competitiveness. And every year that we have like many papers publishing in those high like impact factor journals. As you can see on here in 2024, we have 73 SCI indexes papers were published. Among them, 53 were SCI indexes publication, 21 publications with IF higher than 10, and 13 of them with IF 5 to 10. So we have also get like many of these recognitions in the community. So we are also very proud of that. And then we are also hoping that we can further elaborate our hard work and then to generate more of the outcomes to share. And our research platform is actually quite good. And we have one of the earliest, the biggest like scientific research institution in China. And we have the journals and as well, so that we have established focusing on the research of like urology, and also we are embedded into the guideline draftings, and we are all clinicians. We are more focusing on the clinical work. Just for example, how can our research help our clinical practice? So every year that we have a lot of like GCP like projects, also starting from 2002, and we have establishing for the standard, and then this is our like just like for the biobank, and then our department initiated for the biobank and also clinical database like development in 2003. And I really hope that in the future that we can have more communications and also collaborations with experts from Japan. And we wanted to learn more from Professor Shigeo. And we hope that we could carry out more collaborations in the future. And to just helping us to be just better. Thank you very much.
Professor Xue's talk. And next we'll move to the next session and welcome Professor Horie to give us a talk about I think the IO is immuno-oncology, right? The immuno-oncology therapy for metastatic urothelial carcinoma.
Okay. Thank you so much for inviting me again, and also thank you so much for Professor Su for wonderful presentation. I'm just overwhelmed by the truly highly advanced system of Renji Hospital, Renji Urology, which is no doubt that you are one of the top 3 in the world. I just feel at this moment that I'm like a frog inside the well, which haven't seen the great ocean, So I think we should learn from you, and I think we'd like to visit Renji Hospital in your future. Since actually that I myself is visiting professor to Shanghai University, China-Japan Medical Institute. So hopefully that I can also visit Renji Hospital too. So today I'm going to talk a little bit about IO therapy for metastatic urothelial carcinoma. And yes, let me quickly introduce my institution. Juntendo was established in 1838 as the first Western medical institute in Tokyo. Juntendo has been famous as a hospital, especially for strong and surgery. And the university was established after the World War II. So the history as a medical institute or medical education institute is relatively short than other universities like University of Tokyo or Kyoto universities and other universities. At this moment, Juntendo is the busiest and largest university hospital group in Japan, but it's not uncomparable to Renji Hospital in many ways. So we do have 6 university hospitals, total 3,500 beds, and 5 hospitals have urology service. But total beds is, I think it's less than 200 beds. So compared to Renji Hospital, it's very, very small. And we always welcome digital observers, hands-on training. And at this moment, we have a graduate student from also from Renji Hospital. But also, hopefully that we would like to collaborate with Renji Urology and Professor Su, and also we'd like to learn from you. Last year, we performed the following operations: robotic prostatectomy, 300 cases, robotic portion nephrectomy, 100 cases, and robotic radical cystectomy, around 40 cases. Those numbers are one of the highest in Japan, but compared to your hospital's, surgical volume, it's very, very tiny. So, we are so, how to say, we are so humble in front of you. So anyway, let me talk about a little bit about the evolution of drug therapy for metastatic urothelial carcinoma. For the metastatic urothelial carcinoma, cisplatin treatment has been the mainstream for the last almost 40 years. And about 8 years ago, IO therapy is now approved in Japan, pembrolizumab, and also nivolumab, and the following avelumab, and is now we can use it after the chemotherapy. And enfortumab vedotin was approved in Japan a few years ago. And by this evolution, the overall survival of the metastatic urothelial carcinoma has significantly extended from the 6 months at the year of embark to almost more than 3 years when we use EV plus IO. And this is very busy slides, but this is from the Japanese clinical guideline for urothelial carcinoma. And when we see the patient with metastatic urothelial carcinoma, we offer a first-line treatment, and if we see the disease progression, pembrolizumab, or no disease progression after chemo, we can do a maintenance therapy of avelumab. And also, enfortumab vedotin is now useful after the disease progression. And also, I'm going to talk a little bit about the 3 major clinical trials, which is a Javelin Brother 100 study, which used avelumab after the chemotherapy, or EV plus pembrolizumab versus chemo in untreated metastatic UC. And finally, the nivolumab plus chemotherapy, addition of nivolumab to the chemotherapy in untreatable, unresectable, or metastatic UC. So my first case is left renal pelvic carcinoma, and which is clinically stage T4. And we applied GC therapy for 6 cycles, which is effective to make the tumor smaller. And following this chemotherapy, we treat patients with avelumab, which further making the tumor small and also to make the disease stable. And the side effect was infusion reaction was no infusion reaction was fun when we introduced avelumab, but after 24 cycles, skin erythema was developed, which was grade 2. So this is a study design of a Javelin Brother 100, and so it's a randomized clinical trial. The subject is unresectable, locally advanced or metastatic UC, and CR, PR, or stable disease with standard first-line chemotherapy and 4 to 6 cycles. And those patients are randomized into addition of avelumab or best supportive care. And the primary endpoint was overall survival, and the primary also analytical population is PDL1 population. So this is overall survival from initiation of first-line chemo. And the patient with avelumab, overall survival was 29.7 months, which is statistically longer than best supportive care alone. And the critical question is there any impact on elderly patients? So subgroup analysis from 65 to 75, over 75, and over 80, you can clearly see that no effect of ages for the effect of avelumab. And especially actually that for over 80 years, still avelumab, additional avelumab is effective for prolonging the overall survival. And also, is there any difference of the side adverse events, especially IRAE, by the category, the patient aged over 65? So compared to the overall population, the chances of IRAE is almost the same, but looks like a rash, maybe a little bit. The population is larger in a patient over 65, but other IR-associated adverse events is almost the same. So avelumab can be used in an elderly population. So avelumab maintenance therapy aims to maintain the clinical benefits achieved from a first-line chemo, such as tumor suppression, reduction, or disappearance. And in this Javelin Brother 100 trial, avelumab maintenance therapy significantly improved overall survival compared to the best supportive care in patients who responded to first-line platinum-based chemotherapy. My next case is the patient who had the right renal tumor, suspected non-clear cell RCC or renal pelvic cancer, which extended to iliopsoas muscle, vertebral body invasion, and also lymph node metastasis. And we did the percutaneous biopsy of the right kidney, which showed invasive urological carcinoma, and we initiated EV plus pembrolizumab treatment. And also, we added palliative radiation to the right iliopsoas invasion. And also, we did embolization of right second and third lumbar arteries. So this is a pre-treatment imaging which shows invasive right renal pelvic cancer with iliopsoas muscle invasion. This is an image of PET CT scan. And also you see the sacral bone metastasis and the lumbar vertebral invasion. This is evaluation by CT scan 3 months after EV plus pembrolizumab combination therapy. So you can see the invasion to the psoas muscle is pretty much improved like this. And also bone sclerosis was found for sacral metastasis. So this is a landmark study for EV plus pembrolizumab which is called EV302 or Keynote A39. So the subject was previously untreated locally advanced or metastatic urothelial carcinoma and randomized to EV plus pembrolizumab or chemo, which is constituted of cisplatin plus gemcitabine. And the primary endpoint is a progression-free survival and overall survival. So this is a summary for progression-free survival. You can clearly see that the EV plus pembrolizumab is much effective, much more effective for the metastatic or locally advanced UC than chemotherapy. And also overall survival is quite significantly prolonged, the overall survival. So now for the untreated metastatic or locally advanced UC, EV plus pembrolizumab should be the first line therapy. So this is the ASCO-GU 2025 update and overall survival in the overall population. EV plus P is median overall survival was 34 months, whereas chemotherapy is 50.9 months. And overall survival benefit on all pre-specified subgroups, actually that there is no difference in any subgroup analysis. So we don't know why patient from North America is not doing good, relatively not doing good. But in other subgroups, always EV plus P was had better result than chemo. And also about the safety profile of EV plus P was generally manageable. Compared to the chemotherapy, EV plus P has more adverse events in the peripheral sensory neuropathy or pruritus, alopecia, and maculopapular rash. Whereas anemia, neutropenia, thrombocytopenia, those hematotoxicity was more prominent in patients who received chemotherapy, and especially treatment-related AE leading to death was EV plus P is only 0.9%, which is asthenia, diarrhea, immune-mediated lung disease, and multiple organ dysfunction syndrome. TRAE in a patient who received chemo, it's also again 0.9%. Febrile neutropenia, myocardial infarction, and neutropenic sepsis and sepsis. So my last case is long-term use of second-line pembrolizumab. So this is a 63-year-old male, and the clinical history was almost 10 years ago. Left renal pelvic cancer was found and referred to our department. So we did a laparoscopic left total nephroureterectomy. Pathology showed urothelial carcinoma, grade 2, P33, and V1 RM0. And adjuvant gemcitabine cisplatin treatment was done for 3 cycles. But 1 year later, FDG PET revealed multiple bone metastases and paralytic lymph node metastases. So we did the first-line therapeutic gemcitabine cisplatin for 4 cycles, and assessment was stable disease. And the treatment was paused for a while, and almost 7 months later, CT scan showed the progression of multiple bone metastases. So we started the second-line pembrolizumab. So this is FDG PET imaging before first-line gemcitabine cisplatin therapy, you see aortic lymph node metastasis and osteoblastic multiple bone metastatic, sternum, left leaves, and left ilium. And this is before second-line pembrolizumab treatment, and multiple aortic lymph node metastasis was noted, and also bone metastasis for cervical vertebra, sternum, and left leaves and left ilium. And so after the long-term treatment, which is total 70 cycles of pembrolizumab, now this aortic lymph node metastasis was well controlled, and also the cervical vein metastasis is resolved, and other bone metastasis is also under control. And this is a changes in bone scan index starting from 2018 to 2024. So BSI previously was 1.15, is now 0 after 70 cycles of pembrolizumab. So this is a landmark study, Keynote 045, which is pembrolizumab as second-line therapy for advanced urothelial carcinoma. And so overall survival, which is randomized into pembrolizumab or chemotherapy, pembrolizumab has more than 10 months, is a 10 months overall survival, whereas chemotherapy is 7.4 months. And the progression-free survival was 2.1 versus 3 months. And response rate is that combination of CR to PR was higher in pembrolizumab's group. 22% is ORR, whereas the chemotherapy was 11.0. And also duration of response. Pembrolizumab, median response, duration of response was 29.7. It's more than 2 years. And chemo is 4 months. So as the second-line therapy, pembrolizumab is clearly effective for the metastatic UC. So this is my final slide and the future directions in drug therapy for urothelial carcinoma. And for the first-line therapy, GC therapy, G-carbo, or those intensified MBAC can be applied, and if we get response, available maintenance therapy can be useful. However, EV plus pembrolizumab is much effective than chemotherapy. So EV plus pembrolizumab would be a first-line therapy for metastatic or locally advanced urothelial carcinoma. And the second-line therapy after chemo or avelumab, EV or pembrolizumab can be applied. After EV plus pembro, of course, we will do chemotherapy with the platinum-based medicine. And still, GC therapy to nivolumab can be applied, which would be followed by EV and also new medicine, edafitinib, which is not approved yet in Japan. So EV has a very powerful medicine for the metastatic UC and local advanced UC. So thank you very much for your attention, and also I really appreciate invitation tonight, and I'm very happy to learn from you, Professor Su. Thank you very much.
Thank you very much, Professor, and we did learn a lot of Okay, so thank you again, Professor Horie, and we did learn a lot about the most recent advances in the immuno-oncology in metastatic residual carcinoma. And later, I'm sure we have a lot to discuss together. And so here we have our next guest speaker, and please welcome Professor Jiao Pan. And Dr. Pan is our current chair of the Department of Urology in Shanghai Renji Hospital, and the young committee member of the urology branch of Chinese Medical Association, and also the member of Medical Robotics Committee of Chinese Automation Society, and a lot of other titles in academic field. So Professor Pan is also a visiting scholar in Strasbourg, and very famous for the robotic surgery for prostate cancer. So let's welcome Professor Jiao Pan.
Thank you very much for your kind introduction, dear Professor Shigeo, dear Professor Xue, ladies and gentlemen. So it's a privilege for me to have a short talk about the treatment for mHSPC patients, especially the current status in China. So let me share my screen. Okay. The main talk of today's topic is the novel androgen receptor antagonist, for example, the enzalutamide for the treatment of mHSPC. There are some content. In China, the incidence of prostate cancer goes up very quickly. When I was a medical student 20 years ago, I think the incidence rate or the risk of the prostate cancer is relatively low. It was about 4.2 every 100,000 people. However, in recent 20 years, with the popularization of the PSA screening, we have found a lot of new prostate cancer patients in China. So if we take a look at the incidence risk of prostate cancer in 2020, it goes up to 10.2 every 100,000 patients. Even in some developing area, for example, Shanghai, Beijing, and other developed province of China, we can see that the incidence rate goes to about 21 patient every 100,000 to the male. So that becomes a very important public health issue for China. However, there is a lot of newly diagnosed metastatic disease, that is to say the late stage cases in China. We can see the MRI, that to say the mortality to incidence ratio for China is 0.45. It's really high compared to some developed country such as Japan and Korea. So that is a lot for us, the Chinese urologists, to do to reduce the mortality rate, especially for the patient with mHSPC. There is about in the United States and in Western Europe, we can see that the incidence rate for the metastatic disease when the patient presented to the doctor was very, very low. Only about 5% of the newly diagnosed case in the United States were the mHSPC or metastatic diseases. However, for China, you can see the figure in the right side. 15 years ago, the incidence rate for about 35% of the newly diagnosed prostate cancer metastatic disease. With the PSA screening and the development of the health conditions, now the incidence rate of the metastatic disease has decreased. However, there is still 30% of the newly diagnosed prostate cancer are late stage cases. So that imposes a very important problem for we Chinese urologists. What is the mHSPC? Metastatic hormone-sensitive prostate cancer means that MPCA untreated with ADT or responding to ADT. That's to say the newly diagnosed, mostly are the newly diagnosed prostate cancer with metastatic disease, excluded with the NEPC or neuroendocrine the prostate cancer excluded. So there is stratification according to the charted study. There are high tumor burden disease and low tumor burden disease. If the patient presented with more than 4 bone metastases with more than one located outside the pelvis or the vertebral column, or presents of a visceral metastasis, that is the high tumor burden. If the patient without such kind of indications or such kind of characteristics, there is the low tumor burden diseases. Enzalutamide is a very important novel androgen receptor antagonist for the treatment of mHSPC. There is a long way from 2019 to nowadays. In 2019, it's a milestone for the enzalutamide in China. It is approved in China for adult patients with metastatic castration-resistant prostate cancer, that is a CRPC, who has asymptomatic or mildly symptomatic disease after androgen deprivation therapy failure and have not received chemotherapy. It should be clear that in China, the approval by the Chinese SFDA and the inclusion of the national reimbursement drug list is totally different. The patient would have the indication for the treatment, but probably the patient sometimes the patient could not be included in the reimbursement drug list. So what is more important is the national reimbursement drug list, because that is the new drug or the new molecules are available to most of the Chinese populations. So we can see that in 2021, the MCRPC indication has been included into the NRDL, and in 2024, the mHSPC the indication was included in the NRDL. That is very important for the Chinese populations because there is lots of the clinical trials in mHSPC stage as well as in the MCRPC stage. Even if in the NMCRPC stage has proved that enzalutamide to be a very effective and a very useful molecule for the treatment of for the metastatic diseases. We can see that in our nowadays in Europe as well as in Asia, there is a lot of new drugs like novel androgen receptor antagonists like enzalutamide, apalutamide, darolutamide, rivalutamide, abiraterone, etc. We can see that enzalutamide conducted most of the clinical trials in different stages, such as mHSPC, high-risk NMCRPC, as well as chemo-naive MCRPC. However, for the other molecules like apalutamide or darolutamide, they conducted the new clinical trials only on several disease stage instead of the host disease stages. That is to say, the enzalutamide has its very important indication from the very beginning of mHSPC to the MCRPC stage. We can see that if we talking about the treatment response for the mHSPC, the most criteria we focusing on is PSA. If we can achieve a undetectable PSA, or if we can have that to say we can have probably a longer time to PSA relapse, a longer time of RPFS or OS. We can see that in key studies of mHSPC ARPI combination regimens, PSA undetectable rate in Chinese enzalutamide groups reached about 76.3. For example, for the AX study, we can see that PSA undetectable rate is about 68.1%. However, it seems that the Chinese ARC study achieves better results compared to the global ARC study. That means the PSA undetectable rate was about 76.3 compared to Titan study, Titan Asia group, and Latitude group. We can see that the Titan group, apalutamide has the similar results compared to Chinese ARCs study. However, for the Latitude group, for example, that is to say the abiraterone plus prednisone achieves less PSA undetectable rate compared to the enzalutamide. And also a real world study has compared that PSA is 90%, that to say when the patient can reduce 90% of their initial PSA. We can see that the apalutamide, enzalutamide, and the abiraterone plus prednisone can achieve about 86 to 89% of the patients who can respond very well to the treatment, just like ADT plus docetaxel and ADT plus NHA. Also, the time to PSA relapse, that to say the PSA progression in mHSPC, is also a very important clinical criteria for the patients in the treatment of mHSPC, because the aim of the mHSPC treatment is to put off the mCRPC stage and offering the patient in the same time a very good quality of life. So the most important sign of the evolution or the progression to the mCRPC stage is the PSA relapse. So if we treat the mHSPC patient, the TTPP is very important criteria. We can take a close look to the ARCS or ARCS Chinese study, Titan Chinese study, and for example, the enzalutamide plus ADT can reduce 78% of the risk for the PSA progression, and also for the Titan study, the apalutamide can reduce about 79% of the patients to have a PSA progression. But one thing is very important: we can not compare very simply these two studies in the same table, because the patient enrollment or the study design is a little bit different. So that probably can explain the difference, or there is other resolution or other response. For example, there's still some difference between the medications from the enzalutamide to the apalutamide. So so what I mean is just we cannot just looking at the data, and we should think it over thoroughly of the study design and the patient enrollment in the head-to-head study comparisons. And also the response rate of mHSPC is also very important. We can see that the ORR of ADT plus enzalutamide is 83%. However, for the single, the ADT alone is 63%. There's a 20% the discrepancies, and the CR rate for the enzalutamide plus ADT is 36%. And also, if we take a look of radiographic progression of mortality risk in different large-scale studies like ARCS, ARCS China, Titan Asia, we can see that ARCS China has the best score. It reduced about the 67% of the radiographic progression in patients with metastatic disease. However, the Titan study showed that it can reduce about 50% of the cases for the progression or mortality risk in the patient radiologic progression rate for the patient with metastatic disease. Compared to the PSA 19, it seems that the radiographic progression in this scale, the enzalutamide has a better score. And also we can see that on the OS benefit, we compare the placebo plus ADT and the enzalutamide plus ADT. We can see that the HR was 0.57. That you see it can reduce the risk of death by about 43%. This is a very encouraging data. In the arm of the placebo plus ADT, the average survival rate is about 47.7 months. However, in another experimental group, that is the enzalutamide plus ADT, the endpoint still haven't reached. If we take a close look about the data or the subgroups, we can find that the regimen that the enzalutamide plus ADT was effective in almost all the subgroups, as well, not only in low volume disease, but also in high volume disease, and also in patient with or without the previous treatment. So that's to say in the first plot for the overall survival, the enzalutamide is almost useful to prolong the survival, the overall survival in all the subgroups. That is a very amazing data. So the enzalutamide and ADT significantly reduced the risk of symptomatic skeleton events. Also, if we look at, there is a very interesting data that firstly, the X study shows that enzalutamide can reduce the symptomatic skeletal event risk by 50%. And also, the latitude study shows that abiraterone reduced the symptomatic skeleton event risk by only 25%. That maybe show that the enzalutamide plus ADT is better for the skeleton event protection. However, there is still some problem for the study design and the patient enrollment. However, in the final analysis of Titan study, there is no significant benefit of apalutamide in the reducing the symptomatic skeleton events risk. That is very weird because, the apalutamide and the enzalutamide are both the novoandrogen receptor antagonist, and they have the very close efficacy for the treatment of mHSPC for the metastatic-free survival and as well as the overall survival. Why the Titan study shows no significant benefit for the apalutamide in reducing symptomatic skeleton events? So there's still a very important question to be solved. And we can see that in different patient subgroups, the enzalutamide still have very good response. The enzalutamide is useful irrespective of prior local or systemic therapy, of baseline PS level, of high or low volume disease, or high or low risk of synchronous metachronous mHSPC, as well as the ECOG scores and the patient age, etc. So that you say, and the enzalutamide is very powerful agent for the treatment of mHSPC in almost all the subgroups for the metastatic diseases. Also, there is some data from China, a meta-analysis for Western China hospital or mHSPC regimens showed that the enzalutamide regimen outperforms other in efficacy and safety in HSPC. If we see the relative sucralfate values, the enzalutamide plus ADT was 93%. However, the apalutamide plus ADT was 73%, and the abiraterone plus ADT versus ADT was 92%. And also, we can see for the low volume and high volume disease, the enzalutamide and plus ADT achieved the best score with visceral metastasis is also the same data, same results. And if the patient without visual metastasis, it seems that the abiraterone plus ADT is better. So for the different patients, we can choose the different regimens. And also very important is that we can not very simply compare the final data of the different studies without considering the different inclusion criteria and the study designs. And for the prostate cancer patient, most patients are elderly patients. Some of them have some severe comorbidities like cardiovascular problems, cerebral vascular problems, and a lot of patients take the Plavix or aspirins or statins in the same time. So the effect of ARPI therapy or other medications are also very important issue for such kind of patient. For example, if we take a look at the statin administrations, the apalutamide can reduce the statin plasma concentrations for about 41% in AUC. So if we use the statin, maybe we should add the dosage of the statin. However, for the abiraterone, it is just by vice versa. It increased the rosuvastatin concentrations and elevated muscular cytotoxicity. So the co-administration is somehow dangerous for such kind of patient. However, for enzalutamide, there is no PK interaction was observed. So for the patient with hyperlipidemia, with the treatment, concomitant treatment of statin, enzalutamide may be a better treatment. And there is also a study for the side effect or the adverse event for the novel androgen receptor antagonist, such as enzalutamide, abiraterone, and apalutamide. We can see that the discontinuation rate in high-risk mHSPC patients treated with ARPI for the abiraterone, the discontinuation rate was 20%. For apalutamide, was 29%. However, for the enzalutamide, it was 10%. I think for Titan study, the discontinuation, most of the discontinuation of the apalutamide for the Asian patient is the eruption of the skin or dermatitis. So that is very important for Asia patients. That's why also in after China study, there's more dermatotoxicity compared to the Western countries. Also, there is some treatment-related AE of patients in high-risk mHSPC. So for the AE leading to treatment discontinuation, the abiraterone plus ADT was about only 11%. The ADT plus enzalutamide is 6.9%. However, for the apalutamide plus ADT is 24%. And as for the dosage reduction, the apalutamide was 70.8%. The enzalutamide was 60.9%, and the ADT plus the abiraterone was 6.7%. So that to say the enzalutamide plus ADT is a very safe treatment regimen compared to other novel androgen antagonist or even the abiraterone. So a lot of phase 3 studies has published in New England Journal of Medicine, which is a golden journal for the treatment of for the medicine. So also the enzalutamide has the only phase 3 evidence of benefit for all mHSPC in China. So there is also some cutting-edge studies for enzalutamide, such as the enzalutamide for the mCRPC. We all know that in apalutamide and darolutamide, they have conducted some studies for example, the Spartan study for the treatment of mCRPC. The difference is the primary endpoint. For the Spartan study, the primary endpoint is metastasis-free survival. However, for this enzalutamide study, we can see the overall survival is the primary endpoint. So that is more solid data for the treatment of mHSPC. We can see the hazard ratio was 0.73. That to say the enzalutamide plus ADT can reduce about 27% of the risk for the disease-related deaths. That means the ADT plus enzalutamide is also very useful efficacy treatment for the patients with mHSPC. Also, the enzalutamide could reduce the risk of a radiographic progression and death in the mHSPC in respective the presence of visceral metastasis. That is very important because in the ARCA study, they have included also the patients with visceral metastasis. We can see in the left side the RPFS. If we take a blue line, the non-visceral group is significantly better than placebo group, and the visceral group with enzalutamide is better than placebo group. Also for the OS is the same tendency. And also, the same treatment shows significant RPFS and OS in both high and low bone metastasis volumes. For example, for the RPFS of the patient with higher bone metastasis, more than 4 lesions, and compared to the patient with the bone metastasis less than 4 lesions, there's a significant difference, as well as the significant difference could be found in the overall survival rate. Also, there is some new studies for the combination study. As we know, for the metastatic disease of prostate cancer, the combination therapy is a very important tendency for the treatment, and also mostly achieve the better results. For example, we can see the TARA-PRO-2. That is to say the patient treated with enzalutamide plus tarazopanib in the OS, and we can see that the tarazopanib plus the enzalutamide can have a better overall survival rate compared to the placebo plus enzalutamide alone. That to say the combination therapy for the patient without HR mutation or without the HR deficiency can both harvest a very good response to the treatment. We can see the hazard ratio is 0.79. That to say it can reduce the 21% of the disease-related deaths for the patient with mHSPC. If we take a look at the subgroup of this TARA-PRO study, the very important is the HR status. You can see that clearly the patient with HR deficiency has a better response. However, if the patient without the deficiency in HR status or unknown deficiency of the HR state, it can still respond very well to the combination of tarazopanib plus enzalutamide compared to the enzalutamide alone. That to say, such kind of combination therapy regimen is very useful for the patient with mHSPC without the HR deficiency. And also the lutetium 177 plus enzalutamide also seems to be very good in the patient with high-risk mHSPC. We all know that in patients with treatment of novel androgen therapy or the chemotherapy, the patient can still respond to the lutetium 177 in the vision study. If the patient has an SUV more than 10, the patient responds very well, and it can prolong the overall survival for about 3 months. And we can see that in this study, the NZP is totally different. That to say, it enrolls 162 patients with high-risk mHSPC naive to chemotherapy or androgen receptor pathway inhibitors. That is to say, the new ADT-treated CRPC patient. So we can see the data is significantly better. For example, if we take a look at about OS, the hazard ratio is 0.55. That to say, it can reduce about 46% of the risk of the disease-related deaths. So there is still some new continuous exploration of CRPC regimes based on enzalutamide plus ADT or other new molecules. We hope that will be very useful for our newly patients, because there is a theory in the oncology, the Cody Goldman theory, with the treatment of the chemotherapy or other therapies, there emerges more and more new mutations, which with response to the which can explain the drug resistance in the very late stage disease that require us to invent more and more new molecules to treat the mutated diseases. So briefly, the metastatic disease of the prostate cancer is a very huge problem for the Chinese urologists, especially for it is a very important issue for the China's public health. And with the new development drugs like the novel androgen receptor antagonist like enzalutamide and other agents, the patients respond very well. They have a better PSA response, better PSA 0.90, and they have a very good prolonged the RPFS and the OS. For nowadays, the combination therapy is a new tendency for the treatment of late-stage prostate cancers. The new TARAPRO studies or Lucian plus enzalutamide studies or other studies will offer the patient new hopes for the treatment and for the late stage mCRPC and give their a better overall survival and preserve in the same time their quality of life. Thank you very much.
Thank you very much, Professor Pan. And through your talk, we learned enzalutamide as an optimal choice for metastatic hormonal-sensitive prostate cancer. And so here we have our last session, the panel discussion, and we have Professor Xu, of course, and also including myself, and also we have two other guests. The first is Professor and Professor Guo is the MD and PhD supervisor, Professor of Urology in Shanghai Zhongshan Hospital, Fudan University, and also the Director of Department of Urology, and also Vice Chairman of the Shanghai Medical Association Urological Surgery Branch, and Vice Chairman of the Shanghai Anti-Cancer Association Urogenital Tumor Committee. And Professor Guo has a lot of other titles in the academic field. And also we have another guest, Professor Baojun Gu. And Professor Gu is also MD and a PhD supervisor. And Dr. Gu is, as Professor Xu just introduced, and got his PhD from Japan, actually, and also did his postdoctoral fellow training in Duke University in the United States. And Professor Gu is the chief physician in the Department of Urology, Shanghai 6 People's Hospital, affiliated to Shanghai Jiao University. And Dr. Gu, as other professors just introduced, has a lot of academic titles. Here we have and also we again have our welcome Dr. Horie and to join us. We have two topics for discussion. The first is how can Chinese and Japanese urology collaborate? This is a very big topic actually. And the second is experience exchange on the management of metastatic hormonal-sensitive prostate cancer patients. So I think as I was told, probably we can just also to save time, we can have our guest speaker to give some comments on both of the topics or either one of these, one by one. So first, let's welcome Professor Xu.
这两个题目就分享了，就中日医生怎么合作，然后怎么管理转移性前列腺癌。
反正有翻译还是说中文更好？
说中文，
翻译干什么？
说中文就行。
我想做我们中日两国呢，我们
So
还
I
是有
think
很多的这个。
between China and Japan, I do think we have a lot of similarities for the practice. I mean, for this like a race per se, and then also there are like many of these like social habits. We are very similar, and also our friendship between China and Japan is also just very strong. Especially, I think we do have a lot of communications in this like urology perspective, and still relatively long lasting. And I remember that two of these older generation like doctors in our department has also studied abroad in Japan for a long time. So now that we really hope that we can accumulate for more like collaborations, and then I do think that we have larger population of the patient, and then we do need some like collaboration programs and with experts like Professor just like Shigeo, and especially focusing on those like metastasis, mHSPC, and I think in China, for the proportion of the patient is reducing. We have been conducting more screenings. So like many of the patient has been screened out in the earlier phase. But however, if comparing for this like prevalence rate in the Western world, and it is still much higher. So I think in the terms of management, in our hospital, we are also trying like very early that we are trying to do some just like for this like new adjuvant therapy before the surgery, and also that including some of just like for this like radio this nucleoside and aspect and also to like supporting the patients like status, and then for them to like get ready for the surgeries. And I think we have been trying like many of different like practices, and then we are providing a like a better options to the patients.
Horie, Professor Horie.
Yeah, okay. Well, on the topic about how can Chinese and Japanese urology collaborate, certainly I think at this moment, most of the Chinese big hospital has a great technology and also a very large surgical volume. So in terms of the technology and surgical skills, we Japanese physicians, especially younger population, need to learn from Chinese friends. So I hope that in the future that we have more interchange of young residents, young faculties members, and also at the same time, probably I think China has more advanced technology of AI using AI. And so the management of, in other words, the data sciences of using AI has, I think, Chinese urological department has much more, advanced knowledge and technology for utilizing AI to do the data analysis. So in those conditions, I think we will have a good collaboration. My department is focusing on more genetic research. And since Professor Su mentioned that we are very close in terms of the genetics, and also it's very interesting that for the hormonal therapy, generally speaking, Asian population has more sensitive to hormonal therapy than Caucasian or Western people. So genetic analysis, including changes of genetic changes in cancer cells or liquid biopsies, like free tumor DNA, analysis of free tumor DNA. I think it's a very interesting point for us to collaborate in near future. But first of all, I think we can have exchange program, and hopefully that we can have MOU at the Renji Hospital, Renji Urology, to have an exchange of people, and we get to know each other more. For the management of mHSPC, and certainly that as Professor Pan presented, that exchange changed a lot for the landscape of the treatment of metastatic hormone-sensitive prostate cancer. And actually that, non-bone metastatic prostate cancer, such as metastasis to lymph node, we now have several cases which have CR and cured of disease by Xtandi or abiraterone. So even a metastatic prostate cancer, it could be curable now. And also we don't have PSMA treatment yet, but hopefully in the future, lutetium PSMA can also have a good efficacy for treating of metastatic or CRPC. Thank you very much.
我有声音的，刚才讲过了，听见了。Dear Professor Horie, Shigeo, did you hear me?
Yes. Now, I can hear you. Could you hear me?
Very nice. Yeah.
Okay.
I remember at 2017, on November 30, we Chinese urologist delegation visited your hospital.
Yes.
Do you remember? I have the picture on the chat room. So very happy to meet you again. Yeah, because my Nihongo is not good, so I then use Chinese. Okay.
Yes.
好的，那有翻译的是吧？那么我把这两个问题
because we have translators, well, I would talk about some of the collaboration between China and Japan in urology. Well, I think firstly, as we have mentioned, so many doctors in China, well, actually they have studied and visited Japan. The next panelist, Professor Hu Baojun, well, has used to get the doctor degree in Japan.
25 years ago, I studied in Tsukuba. During the Tsukuba, at the National Institute of Advanced Technology, that means AIST. I, as a researcher or postdoctor at Tsukuba for 1.5 years, but I cannot learn Japanese very well, so I only speak English and Chinese. 所以我想这个有翻译啊，我想这个互相的学习非常重要。
Well, I think our mutual learning is really important. Actually, for so many doctors, they have studied and visited in Japan, and 8 years ago, well, that is the fourth
China and Japan Medical Exchange Forum. 在他们的顺天堂医院啊。那么我也知道这是一个为日本
in the hospital of Professor Horie Shigeo. I also know this is the very top-level hospital in Japan. And at that time, you did some robotic surgery of prostate cancer, of the radical surgery. And at the same time, it is a streamlining in so many hospitals in China, including our department. We're all learning online. So that is already 8 years ago. So I think the mutual learning and exchange is really significant. And for the second question, well, I think for the mHSPC, I would have 3 things to mention. Well, firstly, to use the ADT as early as possible, together with enzalutamide. For the second generation, anti-androgen medication for the OS benefit would be very obvious. And secondly, we also have initiated the PISMA PET-CT scan to diagnose the prostate cancer to help us the early detection of the small metastasis to the lymph nodes and to help us to do the more precise staging of the tumors. And thirdly, well, if the condition allows, we can do the genetic testing as early as possible. Like for the HR homogeneous genes, especially for BRCA2, also be prepared for the following treatment regimen. So I think, well, with the deeper and deeper understanding for this disease, finally we should have clinical trials, including the RLTs, including the LU177 PISMA, to initiate clinical trials. We know it is already approved in CRPC, but for the mHSPC, if we see a patient with more than 10 lesions of the bone metastasis, maybe at the same time with ADT and the anti-androgen medications, at the same time, if we can use the RLTs. But now, also it is very expensive, but so many companies, they have already invested in so many factories in China. So maybe 2 years later, we can manufacture these RLTs on our own, but still it needs the cooperation from different teams. So this is my comments, and thank you.
Next speaker is.
堀江先生、ティータイム難易度でちょうど日本語を話します。
上手です。
実は今回のセミナー、先ほど講演した薛先生はうちの上海検驗機関学会の会長、全国中国全国の検驗機関医者の協会の副会長、日本薛先生はよく日本の検驗機関の先生の考慮したいんですが、この財務は実際は2、3年前よくやりたいです。今度はやりました。本当にありがとうございました。堀江先生。日本とちょっと違いますので、中国の検驗機関学会の会長と病院の副院長として薛先生はパワー持ります。だから私たち別の病院のでも全部上海の検驗機関の医者のリーダーです。だから今度はもし上海の検驗機関の学会ある時はぜひ堀江先生のイベントして上海やってきて、
はい、はい、ぜひ行きます。はい。
はい。通訳言いますので、専門のことは英語と中国語べきしてあります。はい。通訳言いますので、はい。这个谈到这个转移性前的技术
when we talk about for the mHSPC, well, here I have a small question to Professor Shigeo. Well, now, because in Japan, for the diagnostic level of prostate cancer, you're always leading the role worldwide. For the first case I see for the radical surgery of prostate cancer is in the hospital of the Japanese university. Well, at that time, that is really pioneering work. Well, because in Japan, well, you're always following very close to the standards of Europe and the US, and always behind is ahead of China. So maybe I think for the mHSPC patients in Japan, for the mCRPC patients are not so frequently seen in Japan. Most of the prostate cancer, they are still at early stage, but you have already diagnosed it. So you have a lot of the early stage patients, right?
Yes, that's right. Thank you very much, Professor Gu. Yes. We don't really have, I think more than 20 years ago, we do have metastatic HSPC for the 20% of the newly diagnosed prostate cancer, but I think now it's less than 10%. However, we do have mHSPC after the radical treatment. So after the radiation therapy or surgical therapy, it's a time lag between the radical therapy and also appearance of metastasis. So I think it's a steady number of patients has metastatic diseases and CRPC. So probably I think by the introduction of more screening program in your country, the percentage of metastatic patients will decrease, but after several time lag, those metastatic patients will come back again. Thank you.
Thank you.
And okay, my second question is that in your hospital, in the Department of Urology, in your outpatient care for the prostate cancer patients, you have seen through the radical surgery to complete the therapy. What about the ratio?
Could you make the question again? I don't...
Just for the prostate cancer patients in your outpatient clinic, to what ratio?
T1, T2 stage to T3, T4 stage
okay. Well, you mean T3? Yeah. So T1, T2 versus T3, T4, 70-30. Or 80-20. Yeah.
Okay.
About 80. Yeah.
Okay. やっぱり日本の患者さん早いですね。中国普通は別々50% to 50%。半分。
Right. Right. Yeah.
Okay. どうもありがとうございました。
ありがとうございます。
Okay, so we have our Professor Jiao here. And Dr. Pan, would you mind also give us some comments?
Thank you very much, Dr. Tong. I think Professor Xue, Professor Gu, and Professor Gu has already given lots of comments for the further cooperation and the further and for the clinical status for Japanese patient as well as for Chinese patient. I think what I would say is just in the name of Professor Xue, we would like to invite Dr. Horie Shigeo come to visit our institution at your earliest convenience. Thank you very much.
Thank you so much. Truly appreciate it.
Thank you.
So as the last speaker, and personally, I want to appreciate and say thank you to Dr. Horie for giving us the overview of a very nice talk in urothelial carcinoma, and also regarding the collaboration between the Chinese and Japanese urology. I think something that gain more and more interest, and as always, is if the different race contribute to the different prognosis of prostate cancer. And as I did my postdoctoral training in Johns Hopkins and in North America, there's a big part of research around in prostate cancer is actually the African American man, and as we all know that the African American man has a much worse outcome if they have prostate cancer. And however, we don't have that much data from Asian population. And last year, our collaborator from Canada in Princess Margaret, Dr. Alexander Salata, and we published a paper together on JNCCN, demonstrating that the East Asian population in our paper is actually a Chinese patient, and we do have a much higher proportion of patient diagnosed with a high Gleason score prostate cancer. And interestingly, the reason why we initiated that research is because about 10 years ago, I'm sorry, it's 2011, that's more than 20 years ago. So Dr. Salata published another paper on JNCI, and it's an autopsy paper, I think. That paper, he compared autopsy results between the Caucasian, which is a patient population from, I think, Russia, and also another part is from Japan, actually. So he also has his collaborator in Japan, and in our autopsy paper, and we actually saw exactly the same trend that we have like much higher Gleason score population, and but one of the challenge we have from the reviewer is that they can easily have like a multi-centers in North America, like Canada and UBC and the United States, but here it seems like we don't have that much busy collaboration between, for example, like China and Japan and Singapore and Korea, Japan. So maybe that is something we can do in the future. And not only the very important thing is other professors mentioned before, for example, genetics results, we can share the data, and also we can share some like the database from the clinical pathological aspects. So and also, like I said, we have AI right now, so we already start to scan all those slides to make them into digital form. And maybe this is a chance that we can. It's easier for us to later share results and pull the data together and publish very important findings. So yeah, really looking forward to this.
Yes. Yes.
Okay, so I think it's already almost 10:20 p.m. in Japan. So we did enjoy, it's late at night, and though it's not that late for surgeon. So I believe everybody in this meeting enjoyed tonight, and we learned a lot from each other, and we do have a lot of interest to visit each other. So looking forward to our future collaboration, and let's physically visit each other in the near future. Thank you very much.
Thank you very much.